Good afternoon, everyone, and welcome to Midweek COVID update for Wednesday, 13th of October. So let me spring straight into who we are. I guess by now we're pretty familiar with these graphs. So we are in a pretty good space now. We can say goodbye to the third wave. All the provinces seem to have come out of the third wave, and we're right down over here now. In fact, if you look at some of these other parameters, they confirm that we really are in a pretty good space at the moment. The proportion of tests which are positive, in fact, is at its lowest level, 3.0% since before the first wave. So that's a very good parameter that we are at a low level of virus circulation in the community. I thought I'd show you this. It's quite an interesting one. It's another parameter which is looked at, and that is wastewater surveillance. Now, wastewater surveillance is not totally new. In fact, it's been used for polio surveillance as an early indication of an impending increase of circulation of the virus in the community, and one or two other viruses as well. So now it's been adapted to looking for SARS-CoV-2, the COVID coronavirus as well. And as you can see, sampling wastewater, because we know the virus is excreted in the stool, lands up in the sewage. We can see it's coming down as the cases come down as well. So sampling at various parts of the country. I thought I'd just show you out of interest that there is another parameter which is looked at, which also confirms that we really are out of the third wave. So this is where we are at the moment, and it's really equivalent to the interwave period of low level transmission. And of course, the very frequent question that gets fired at me, the $64,000 question is, when can we expect the next wave, the fourth wave? So we can look at a couple of parameters. First of all, if these waves obey a regular cyclic periodicity, and we've chatted about this in a few occasions before. We're looking at these first three waves. There was an interval of about 95, maybe up to 100 days, fairly regular interval between these waves over here. And the duration of the waves was also fairly constant in the first two waves of about 100 days or so. Sorry, about 75 days, the interval about 100 days, about 75 days, 76 days. The third wave was a little bit different in that the duration of the wave was a bit longer than the first two. This was about 130 days. But nevertheless, if this cyclic periodicity does hold, then we can really expect a fourth wave, I guess, the end of December, beginning of January. This is where we would normally expect it. There are, however, other factors which we do need to look at. First of all, the buildup of natural immunity. We know that people who are infected develop a natural immunity. And if this natural immunity is prevalent in the community, it may also dampen down the extent of a fourth wave or even a fourth wave itself. Now, looking for natural antibodies in what we call seroprevalence studies. Sera means you take blood samples and looking for antibodies in a sample of the population. We get a figure of about 40 to 50% of individuals have got natural immunity from infection with the virus. However, the problem with natural immunity, we're not really sure. It seems to be pretty variable in terms of how durable, how long it lasts, how effective it is, and also how effective it is against different variants. So we can't totally predict on natural immunity. Then we come to vaccine coverage. Obviously, vaccine coverage is a major determinant of immunity in the population, and we'll come to that just now. Human behavior, we know, has triggered off the first and second wave, and maybe the third wave as well. Will that be a factor triggering off the fourth wave? That we'll have to see. And then obviously new variants would be a major determinant of the fourth wave. So let's just look at these in turn. First of all, the vaccine coverage. So we are progressing. We're getting close now to 20 million doses of vaccine have been distributed in the population. 13.7 million individuals have been vaccinated, either fully vaccinated or partially vaccinated. There's just over a third of the population have received at least one dose of vaccine, or about 23% of the total, so going up to about a quarter of the total population, including children. So we are progressing. They're not quite as good as we would like. This is the last 24 hours, just under the 200, or just over, I should say, just over the 200,000, but under the 250,000 doses, which we need to do on every weekday if we're going to get to our target of 70% of the adult population by the end of the year. I personally am a little bit skeptical that we're going to reach that target. I think we're going to reach that target maybe into the early months of next year. Some of the provinces are doing reasonably well, like the Western Cape, with 43% coverage of the adult population. Gauteng, not so good. We're lagging behind in Gauteng, with only 31.4% of the adult population being vaccinated. So certainly Gauteng and some of these other provinces have got quite a bit of catching up to do. But the vaccine program is rolling out, and hopefully we are going to get close to that target in the weeks to come. Now just look at human behavior as a trigger. We certainly identified various functions, various parties as a trigger for the first wave. Similarly, for the second wave, for example, with the Rage Festival, was incriminated also as a triggering factor for the second wave. The third wave, we're not quite sure. We can't really pinpoint any particular functions. But what does worry us now, where we are at the moment, let me get the other pointer up. What does worry us now before the fourth wave is, first of all, that there's going to be a Rage Festival, inadvisably so, but there is a planned Rage Festival, unfortunately. And also the elections with huge turnouts of people out, fortunately outdoors mainly, outdoors much less transmission than indoors, but nevertheless, we know, for example, the beginning of the year in India, that their elections were a major factor in triggering off and to some extent driving their massive wave of COVID. So there are little worries about both the election as well as Rage that this might not trigger, might well be a trigger to trigger off the fourth wave. Hopefully not. And then, of course, we come to the variants, alpha, beta, gamma. Each of these variants has been responsible for driving epidemics in some parts of the world. And Delta, of course, is the main variant which is circulating now, a variant which is causing a lot of worry because of its high transmissibility and its infectiousness. And just to show you, and I think I've shown this before as well, in India, the Delta variant is what triggered that massive epidemic in the earlier parts of the year in India. Gamma variant in South America. And in South Africa, the Beta variant driving our second wave, the Delta variant driving our third wave. Hopefully, we won't get any other further variants, but this is unpredictable. Unfortunately, we don't have the tools to be able to prophesize when, where, and what kind of variant will happen in the future. So that becomes one of the big unknowns. Now, in a little, I've had a number of queries, both in this forum as well as in other forums, about booster doses. And I want to show a couple of slides and talk a little bit about the necessity for booster doses, the planning for booster doses, and what lies behind it. It's really two studies which were published in this prestigious journal, the New England Journal of Medicine, where they indicated that there seemed to be a waning, a decline, a decay of the humoral, the humoral means the antibody response over 6 months. So in this study, they looked at healthcare workers, between 4,000 and 5,000 healthcare workers. They followed them up over a period of 6 months. And at 6 months, there was certainly a significant decline of antibodies. When I look specifically at neutralizing antibodies, there's quite a marked decline in the first 3 months and then a slower decline up to 6 months. But at 6 months, there seemed to be a significant decline of antibodies. This was then followed up with an effectiveness study. And what they did find at 6 months is that there seemed to be a higher incidence of breakthrough infections, individuals getting illness and getting infected the earlier they were vaccinated. And they looked, for example, at elderly individuals. Those elderly individuals that had had been vaccinated more than 6 months previously, there was a 1.6-fold increase of breakthrough infections as compared to individuals that had been more recently vaccinated. So this seemed to be the kind of motivation for, in Israel, of course, a very widespread booster vaccine, giving a third dose of the Pfizer vaccine after the initial 2-dose vaccine regimen. These publications, however, were followed quite rapidly by rebuttal publications. So this one appeared fairly soon after that in The Lancet. The Lancet, very prestigious, the oldest medical journal, in fact, in the world. And this came from pretty senior individuals from the WHO, from the FDA in the United States, from various academic departments in Washington, University of Oxford, and so on. And this was the nub of their editorial. The currently available evidence does not show the need for widespread use of booster vaccination in populations that have received an effective primary vaccination regimen. And there were a number of other articles. I'll just show you one or two others. This also from Stanford University in the United States, University of Pennsylvania, and also the United Kingdom. The case for universal boosters is weak and the benefits are unclear. So clearly quite critical of the Israeli studies. This is an editorial in the journal Nature. I'll just look at this very pretty picture over here showing antibodies on the COVID virus. Antibody levels do wane on those vaccinated, but other immunity remains. And this is really the nub of the argument against booster, that even if neutralizing antibodies do decline, there are other antibodies which also mediate protective immunity. We call them blocking antibodies or non-neutralizing antibodies. Also neutralizing antibodies, even if the levels become low, the cells that produce these antibodies, what we call them B cells, and then the lymph nodes, if one does get exposed to the virus, one gets infected, these B cells will rapidly produce neutralizing antibodies and protect individuals, even if you can't demonstrate them in a study, for example, that these neutralizing antibodies have declined. And then lastly, we also have what we call cell-mediated immunity. In other words, immunity is mediated by immune cells, which are also protective. And these have got a long durability, certainly well past 9 months, probably even well past a year as well. So the scientific evidence doesn't seem to support the need for boosting, even despite those 2 Israeli studies. There's a technical problem, which one of the questioners has sent in, and that's the Israeli government is actually, I'm not sure if any other travel, it's a requirement for any other country, but certainly for Israel, that you need to show proof of vaccination within the last 6 months. Certainly United Kingdom, United States, those countries don't demand that. They just demand being vaccinated. How this is going to be handled, I'm not quite sure. I don't have an answer for that as yet. I will bring it up. But certainly that would be a problem because a number of individuals, particularly healthcare workers, have received their vaccination past 6 months. Now, where are we now in terms of boosting for this country? I think there will be booster doses being offered in 2 circumstances. The one are individuals whose immune systems are suppressed, either they're on various drugs or they're transplant recipients or cancer patients and so on, and they don't respond that well to the vaccine. So certainly that group should and probably will be offered a booster dose, an extra dose over and above the primary vaccination, the initial vaccination. And the second group are individuals who are vulnerable because of the high-risk exposure. So those are the healthcare workers. So the healthcare workers and the people whose immunity is suppressed, they will probably be offered booster doses in the near future. But there aren't plans for generalized booster doses for the rest of the population because at the moment, there isn't good scientific evidence that there's a need for it. Now, lastly, I just want to touch on something which I think is of importance, and that is that we are, as I mentioned earlier, in the interwave period now of low virus transmissibility. It does not mean that the virus has disappeared. For example, on the national figures, yesterday in the last 24 hours, there were 592 daily cases. There are still some cases at a much, much lower level. It used to be in the thousands before, but nevertheless, there are still the occasional cases still coming through. In fact, the Hatsolo data has also picked up 15 new cases the previous week, 16 new cases in the last week. And this is probably just a fraction. There are probably a larger number which don't go onto the home monitoring program of Hatsolo. So it's just to kind of caution that the virus is still out there. It is still circulating. And what I do want to kind of amplify, and I did touch on it last week, and that's the situation of, first of all, of the Delta variant, which is circulating, which is highly infectious, and also the situation where people come together in a crowded situation, particularly indoors, particularly where there's poor ventilation, the so-called super spreading environment. I spoke last week about the study done in this county, Barnstable County, Massachusetts. It's become a classical study now, where the vaccination coverage was certainly much higher than what we've got, just under 70%. And the cases, 74% of the cases which occurred in this outbreak were in fully vaccinated individuals. And of these cases, 79% of those that were ill were fully vaccinated. Those that were hospitalized, 4 out of the 5 were fully vaccinated. There have been a number of other studies, for example, the study in the nursing home in France, where the vaccination coverage of the residents was 97%. And they had quite a significant outbreak. Of course, the great majority of those that were ill were fully vaccinated. Another study done in healthcare workers, again, demonstrating that even in a highly vaccinated population, if there's Delta virus circulating, which is, of course, the main variant now, plus the fact that you have a super spreading environment, functions, parties, those kind of situations, even if one is vaccinated, vaccination doesn't seem to provide that much protection in that situation. Another interesting thing which has been found, that individuals who are infected despite being vaccinated, the amount of virus that they carry, in other words, the infectiousness, is the same whether they're vaccinated or unvaccinated. So the bottom line, what I really wanted to kind of emphasize quite strongly, is that we are still seeing cases now, even in the interwave period. And secondly, that even if one has a vaccinated population, one must still avoid those highly transmissible situations and super spreading environments. We still, at the moment, where we are now, even in the interwave period, still need to keep up with the wearing of masks properly, hand sanitizing, and avoiding these functions, avoiding these social functions, which can also now be one of the factors which could trigger off our fourth wave. So thank you very much for listening, and keep well, keep safe, and we'll see you next week. Thank you.